My name is Rasheng Shu, and I'm a cerebrovascular and endovascular neurosurgeon at Johns Hopkins. Today, I wanted to talk about a new treatment for intractable pediatric epilepsy. So, pediatric epilepsy is actually a very common condition that affects about 0.5 to 1% of all children. And intractable pediatric epilepsy, which is medically resistant to multiple anti-epileptics, can affect approximately, 10 up to 30% of children with epilepsy. And traditionally, for poorly localized seizures, children can undergo a procedure called hemispherectomy. This is a fairly invasive procedure where the pediatric neurosurgeon goes in and makes major white matter disconnections in the brain to prevent the areas that are seizing in the brain to generalize and affect the contralateral hemisphere. In the last couple of years, I have worked with Dr. Dodie Robinson and the pediatric epilepsy team at Johns Hopkins to really push forward a new minimally invasive endovascular procedure called endovascular hemispherectomy. This is a procedure where instead of surgically making the disconnections, we go into the hemisphere that needs to be treated, and very selectively and very carefully, we embolize and get rid of the blood flow to the areas of the brain that are seizing. We divide the hemisphere usually into 4 treatment sessions, and slowly over the course of 4 embolization sessions, we get rid of the blood flow to all parts of the brain on that side of the hemisphere. We're very careful to leave the blood supply to the basal ganglia and the thalamus. Earlier this year, we published a case series of 4 patients who underwent endovascular embolization for medically refractory pediatric epilepsy. So these 4 patients were treated at Johns Hopkins between 2022 and 2024. And these patients were selected based on contraindications to conventional surgical approaches and, of course, the failure of at least 2 anti-seizure medicines. Our outcome measures included seizure frequency reduction, functional improvements, and procedure-related complications. And in these 4 patients who were aged between age 2 and 9 years of age, we performed a total of 12 embolization procedures. 3 of these patients achieved freedom from seizures, while 1 patient who was undergoing a palliative procedure showed a significant improvement in seizure frequency. No patients required rescue open surgery, and no patients experienced hydrocephalus or neurologically unexpected complications during the follow-up period. So endovascular embolization is a very promising, minimally invasive strategy for pediatric patients with refractory epilepsy, particularly when anatomical or medical considerations prevent traditional surgery. And we are very excited to bring this surgical technique to more patients with pediatric epilepsy.